All right, good evening, everyone. My name is James Blatz. I'm the Associate Vice President of Partnerships at the University of Manitoba. I'd like to welcome you to our third Café Scientifique of the fall season. Now, on behalf of Dig Vergeas, it's great to see such a fantastic crowd here this evening. These cafes are an initiative of the Vice President of Research and International, the office here at the university, and are meant to bring the public closer to our amazing health researchers to learn firsthand about what they are doing in this friendly and comfortable atmosphere. I think it doesn't get much more comfier than this, and it certainly looks like everyone's settled in with a standing room only crowd, so that's fantastic. We have a very exciting and very relevant topic for discussion for tonight's cafe, one that has obviously resonated with many of you, or you wouldn't be here tonight. Endocrine disorders, overeating, obesity, and diabetes. And our medical researchers of the future will be sharing their perspective with you on the research they are undertaking as graduate students. For those of you that may not be aware, graduate students are the fuel that drives the research enterprise at the university. They work under the supervision of faculty members doing cutting-edge research in a variety of fields, and either go on to work in industries or teaching and doing research, and will likely be the people who find solutions to many of the health issues plaguing us today. I'd like to introduce you to our moderator for this evening, who will tell you more about the panelists and some of the ground rules that will guide the discussion this evening. Dr. Jonathan McGavick is the Robert Wallace Cameron Chair in Evidence-Based Child Health and Associate Professor in the Department of Pediatrics and Child Health in the College of Medicine at the University of Manitoba. And he told me to end there, but I've got another paragraph, so we will continue. He established the Center for Physical Activity and Cardiometabolic Health at the Manitoba Institute for Child Health, a research affiliate of the university where Dr. McGavick studies his research. His lab is working to determine the role of physical activity in the prevention and management of type 2 diabetes and the mechanisms to explain these effects. Please welcome Dr. Jonathan McGavick.
Thank you, Dr. Blatz, and I will move over here and invite Dr. Ho to come up and have a seat. Here, I think, or there? You can have a seat. She has a mic here, okay. So my notes are on my phone, because I'm trying to save some paper. But welcome everyone. Can I get a show of hands? Who is here as a scientist or a graduate student? All right, good. We will be turning to you for those really hard-pressed questions. Who is here because they are passionately interested in the topic of obesity, metabolism, and diabetes? Perfect. Who is here because they want to be a medical student or a graduate student? All right, good. This will be intimidating for you. So before we get started, the way it will work, I'll do some housekeeping. Each panelist will speak for 5 minutes, and we're very lucky tonight that we have the future minds in health research in Canada. So tonight our panelists are graduate students. I recognize a lot of faces because I come to these, so I can tell who's been here before. Normally you see scientists that have been through the ropes and have established their careers. These are undifferentiated. They still have their lives and their careers in front of them, so it's going to be very nice to hear from them. After their talks, we'll open the floor to discussions, and I will pass the microphone around, so please put up your hand very high or yell out to get my attention. We will be video recorded in the back, and everything will be on the website, on the U Manitoba website, umanitoba.ca/Café Scientifique. We'll end at 8:25, so if you have a pressing question, please get it in. There are refreshments here. We'll ask that you wait till you grab refreshments until our panelists have finished their presentations. You'll notice that there are evaluation forms on the tables and the chairs, so please try to complete those before you leave. If you are Twitter savvy, for those of you with cell phones here, you can hashtag this event, and I'll try to be hashtagging throughout. You can go to #Café Scientifique, and the information that's presented will be put throughout. And then finally, we do have a physician on our panel, and we know that some people have questions that are medical in nature, maybe about their own treatment or their own therapy, but we ask that you try to keep it as basic as possible, as general as possible. Our physician can't give you your own medical advice in front of everyone, unless you want to open up your patient chart in front of everyone and discuss your issues. So we'll try to keep the questions as general as possible. So from my left to my right, it'll be a little different. We have Dr. Janice Ho, Dr. Housekeeping, Dr. Martin Sénéchal, and soon to be Dr. Jennifer Enns. Dr. Janice Ho will be our first presenter. She obtained her medical degree from the prestigious RCSI, Royal College of Surgeons of Ireland, with honours. She went on to do her residency training at Dalhousie University, where she completed her internal medicine residency and passed both her Canadian and American board exams. I have a better. Can I do my own voice, or does it have to be on there? All right. Dr. Ho is now completing her endocrine fellowship at the University of Manitoba, and she'll be talking about her current experience as a physician and a physician in training. Dr. Sénéchal is a CHR postdoctoral fellow. His research path was chosen to advance research in the field of obesity and kinesiology and provide a healthy future for people. Dr. Sénéchal has expertise in obesity and exercise physiology, and his ultimate goal is to produce knowledge that will allow novel strategies and tailored exercise interventions for obesity and its comorbidities. Dr. Jennifer Enns is a PhD candidate in the Department of Physiology and Pathophysiology and is based at the Canadian Centre for Agri-Food Research in Health and Medicine at St. Boniface Research Centre. She is studying how functional foods can help people with metabolic and cardiovascular disease. Her research focuses on foods that contain omega-3 fatty acids and their role in regulating how dietary fats are stored and metabolized in the body. Hannah Vakili is a PhD candidate in the Department of Physiology and Pathophysiology in Endocrinology and Metabolic Disease Division. She's also a recipient of a prestigious CHR doctoral award. The intent of her research is to extend the understanding of overeating as a stage in developing obesity and adverse hormonal changes that are associated with adiposity during two of the very critical periods of lifetime, puberty and pregnancy. She hopes that her findings will help the development of management and even prevention of therapeutic strategies to stop the obesity epidemic. So now we'll open up the panel, and we'll start with Dr. Janice.
Thank you. So thank you for allowing me the honor and the pleasure of speaking to you guys tonight. So I am an endocrinology fellow, which means I'm in training to be an endocrinologist. And as a result, I see a lot of people that have diabetes. And what we're seeing is that the prevalence of diabetes, type 2 diabetes, is increasing worldwide, but in Canada as well. And in fact, when we look at Canada, we compare it to North American and European countries, it ranks the third highest. And this is associated with the increased rise in obesity as well. And because of this, it's a very important healthcare matter, both for the individual that has diabetes, but also to society as a whole. Because when diabetes is not well controlled, it is associated with lots of medical complications, including increased risk of things like heart attack and stroke, even death, increased risk of death, and it's also associated with diabetes affecting the eyes, the kidneys, and the feet. So it does have a significant impact on the individual that has diabetes. And as a result, there's more and more research that's being put into diabetes and the link with obesity and diabetes. In my experience, what I'm seeing is, despite the fact that there is more and more research going into diabetes, there's still a few gaps that we see and areas that we don't have all the answers to. And I'm just going to talk about two of these areas that I've identified. And the first is, there's a lot of research going into diabetes and where we need to get patients to keep them healthy. And we look at things like blood pressure, cholesterol, blood sugars, and we have well-defined targets. There's well-defined targets for all these three areas, and it's recognized that if we can get patients to these numbers, we can really protect them and keep them healthy. But one area where I'm seeing that we aren't quite doing that is that only about 50% of people actually reach their blood sugar target, their diabetes target, and only about 50% reach their cholesterol target, and only about a third actually reach their blood pressure target. And if we look at all three in combination, only 13% are reaching that target. So 87% of patients aren't reaching that target. So I see that as an area where we don't have all the answers, and we're not getting patients into, getting individuals into those targets. Another area that I see, where I see that we don't have all the answers, is that link between diabetes and obesity. So a recent study came out in a large, well-respected medical journal where it looked at overweight patients that had type 2 diabetes, well-established diabetes, so diabetes for a number of years. And they had these overweight individuals lose weight, and they did lose weight, and they did so successfully. Their blood sugars became better, they felt better, but there was actually no change in their risk of heart attack and that increased risk of death. So that was a very interesting study, and I think that there are areas where we still don't have all the answers. And the next three individuals are going to speak on some of the research that is being done right now between diabetes and obesity. Thank you.
So I think next up we have Dr. Sénéchal.
Okay, so first of all, thank you for the kind of introduction earlier. So as Dr. Megavec said, my name is Martin Sénéchal, and I'm also part of the Physical Activity and Cardiometabolic Health Center. So today I'm going to talk a little bit about my interest in terms of research. So I'm really interested in physical activity and risk factors, typical risk factors for type 2 diabetes and cardiovascular disease. And so before moving further, I would like to define physical activity, which is basically just any movement produced by the skeletal muscle that increases energy expenditure. And over a time, or a long period of time, that increase in energy expenditure is going to improve health. And so if we start to look at the data on energy expenditure, there's some data that suggests that there's a decrease in occupational energy expenditure during the last 50 years by about 100 kcal per day. And we already know that a lot of people don't reach the physical activity guidelines, so they're not currently active, and therefore they maintain a low energy expenditure. And so it is kind of critical because if we look at the data, we also observe a parallel increase in obesity rate, also an increase in type 2 diabetes prevalence, and also cardiovascular disease. It is critical because the World Health Organization said that physical inactivity is the fourth leading risk factors for premature mortality. And there's a whole body of evidence out there suggesting that physical activity has the potential to reduce premature mortality by as much as 50%. Also, physical activity is known to reduce the risk of breast cancer, colon cancer, hypertension, and also heart disease by 40 to 60%. So there's no doubt about the benefits of physical activity in terms of preventing those chronic conditions. Despite the fact that people know that physical activity is good for your health, people are aware of that, they don't necessarily exercise. And one of the reasons why they don't exercise is because they don't necessarily reach their goals. And so they stop exercising, they get discouraged. While on the other hand, you're going to have other people who's going to exercise, they're going to reach their goal, and physical activity is going to be part of their healthy lifestyle. And so what I mean by that is there's some responder and non-responder to physical activity. So some people withdraw the benefit effect of exercise, and some people won't withdraw the same benefit while they are doing exactly the same program interventions. And so I think it is really important to try to better understand that to be able to tailor intervention for people. Another thing I'm really interested is people who have high body weight, but they are free of typical risk factors for diabetes, for example, cholesterol, blood pressure. We always have that preconceived idea that when people have high body weight, high body mass index, they always have those comorbidities that comes with. But in fact, it's not always the case. There's about 30% of people that have high body weight that are basically healthy. So I think it is really important to study more deeply those individuals to understand a little bit better what's happening here, because those people has the potential to carry a lack or an absence of risk for premature mortality in the future. And so that's kind of what we are really trying to do at the Manitoba Institute of Child Health. Our group is running different kind of study right now on different type of exercise, different mode, different intensity of exercise, to make sure that we can tailor interventions for people at risk of diabetes. And I would I would sum up here by saying that exercise is probably the best medicine we have so far. It's just not well prescribed because we don't know that much about exercise. We just know it's going to improve your health, but we don't know exactly how it works. And I think that's where we have to go from this point. So I would like to thank all the people who funded our group, our research, this Café Scientifique, which is a really good opportunity to have the chance to talk with a lot of people. And I will turn to my colleague, Jennifer. I talked to you a little bit about exercise, and so she's going to talk about the other side of the medal, which is more nutrition.
Okay, well, thank you very much for letting me... allowing me this chance to share a little bit about my research with you. My research focus is dietary fats and oils. And just by a show of hands, how many of you are familiar with, say, the term saturated fat? Okay, how about omega-3 fats? Yeah, it's a pretty familiar term, I think, to you guys these days. But in the general public opinion, I think that when we talk about diet in the context of obesity, fat is still sort of seen as the enemy, something we want to generally eliminate from our diets. But I think that's something that we don't always recognize about fat, is that it's essential to our diet. It's an important source of energy for us, and it's important for all of our cells and organs. Fat is part of the structure of those. And it's also essential in our diet for absorbing certain nutrients, like certain vitamins. And the other thing about fats is that they're not all created equal. Some of them are known to have benefits to our health, and some of them are known to be harmful to us when we consume them in excess. So my research focuses mainly on omega-3 fats. And there's a number of reasons that have been shown in studies why omega-3 fats are considered healthy. The first one is that they're considered anti-inflammatory. So obesity can be considered a inflammatory disease where the fat cells store excess fat and they become sort of stressed and they start to malfunction and inflammation develops in the fat tissue. So omega-3s are anti-inflammatory. They kind of counteract that inflammation and they can help bring that back down. And the other two reasons why omega-3s are considered healthy have more to do with cardiovascular disease. But as we've heard, obesity is really a risk factor for cardiovascular disease. So I think definitely relevant in this context. Omega-3s are able to prevent blood from clotting. So in an artery that's narrow or stiffened, if a blood clot forms, you're at risk of having the blood blocked in that artery, and you're at risk of a heart attack or a stroke. But omega-3s are able to prevent blood clotting, or at least to suppress it. And they're also antiarrhythmic, which means that they can suppress abnormal rhythms of the heart. So omega-3s, if they're good for us, how do we get them into our diet? Well, they're found in fish, fatty fish like salmon and mackerel, but as Manitobans, we probably don't eat fish 3 or 4 times a week. It's just not really usually a staple of our diet. So luckily for us, omega-3s are also found in plants such as canola and flax. So we can get omega-3s from canola oil or flaxseed oil. So in our lab, some of the research questions that we're asking are do omega-3s have beneficial effects in conditions like obesity? And do omega-3s from plant sources are they as beneficial as those from fish sources? Because there's a lot more research done on fish oil. And so we use different disease models in our lab, and we're also conducting some clinical trials, not only with omega-3s, but with other food products as well. And if you're interested in looking into more of those clinical trials, you can check out the St. Boniface Research Center website. There's lots of info up there. But generally, we're working on these clinical trials, and other research have conducted clinical trials on omega-3, so there has been a fair amount of work done, but those trials simply haven't answered all of the questions that we have about whether they're beneficial or not. Generally, the clinical trials that have been done are either not long enough, they're not large enough to give us a good statistical answer to our questions, or they're done in diverse populations, so we can't necessarily generalize our answers from a population that has existing disease to one that is healthy. So we're still looking for new approaches to study the relationship between diet and obesity.
Hello everyone, so I'm Hannah, and as Dr. McGowan mentioned, I'm a PhD candidate in the Department of Physiology and Pathophysiology, and my research is focused on overeating as a stage in developing obesity. But I'm mostly interested in obesity and overeating in two very critical stages of our life when we are at great risk of becoming obese. I'm talking about puberty and pregnancy. So based on what we have heard so far from other panelists, we have a sense of the obesity epidemic and how it's critical to stop it because it is connected with many other related diseases. But in order to stop it, we need to understand what is the state of obesity. And so, okay, the question is here, what is contributing to an obese state? Well, it's too much of food, to be sure, but we are using too much of processed food that are rich in fat and also sugar levels and lots of non-food additives. And also it's our sedentary lifestyle. We are spending more and more of our time sitting and looking at our screen at work, when we go home and still sitting and looking at our screen for our entertainment. But if that was all, that was the lifestyle that we have and the diet, then the prescription of we should be eating less and healthy and exercise would work for everyone. But clearly it doesn't. As Dr. Sénéchal mentioned, we have responders and non-responders, and there is a reason, because we are different. We are different ages, different genders, we live in different places, eat different things, and above all, we have different genetic backgrounds. I'm talking about the DNA we inherited from our parents. Even though we have them very similar, but still it's not exactly identical. So that means we are unique in our own way. And that prescription of eating less and healthy and getting more exercise is not going to work for everybody to the same. And the other question here is, why is it so difficult for some of us here to stop overeating, to control our appetite? It's not very easy for most of us. And also, why we can't do exercise well, why we are not so motivated. I think the answer seems to be our hormones. Or, to be more clear and particular, hormones are not doing what they're supposed to do. And my research is about studying hormones, how they are produced and how their production is controlled. I'm sure you have all heard about one of the hormones called insulin. Yes, it's a treatment for diabetes, but also is a natural hormone in our body that is produced to control our sugar levels. Every time we eat after a meal, there is a rise in our sugar levels, and this is when it's the time for insulin to be released, and it's getting the message to other parts of the body that this sugar needs to be taken out and be used as a source of energy. But this time, basically you can see what we eat, and the diet controls and determines how much of insulin should be in our body. But now imagine a person who just had a big meal this time. It's going to be a big rise in sugar levels, and this is much more than what we need. It's extra. And in this case, insulin's job is to talk away that extra sugar into form of fat. So shunts sugar to fat. So more insulin, more fat. It's okay if we do overeat once or twice. It's not going to be a problem. But if we keep overeating, that's the problem starts. This is the time that our body is going to go to a state that we call it delusive starvation. Our body is believing that we don't have enough energy. We're starving. So that's the time, even we just finished the meal, we're going to reach for a bag of chips and a bar of chocolate on top of what we've had. Even things go wrong further with other hormones. There is another hormone called leptin. Its job is to tell the brain cells that we should stop eating. But if we have just overate and we have too much of insulin, it's going to make the brain cells go deaf to the message from leptin. And we're not going to be able to stop overeating. And this is when we reach for another soda, another bag of chips. And it's just going to go to a vicious cycle. So you might be thinking, okay, we can't control what we eat, and how we're gonna have our habit of eating, well, we can do the exercise. I'm gonna go to gym tonight and I'm gonna walk or jog for another mile, or I'm gonna go swim. But even the research tells us it's not as easy as it sounds for people who overeat for a good amount of time, for months, for years. This is because that extra levels of insulin that I'm talking about overeating, it's going to affect part of the brain that is responsible for motivating us to go exercise. So basically you can see if we've gone too far with overeating, then the body is reprogrammed to a state that even tells us, directs us to a wrong direction. It tells us we should be eating more and we should be not doing exercise. All right, this is fine. And I don't want to give that impression that we can blame everything on our hormones. That's not true. And we don't have a personal choice. Even with that personal choice is not as simple that we think. I'm going to tell you a story about this. In fact, it's a sad one. Once upon a time, it was so difficult to find a children in pediatric clinic who's suffering from non-alcoholic fatty liver, as this is a disease that is normally reserved for adults. Do you think this is a personal choice of that kid to suffer from an adulthood disease? Absolutely not. This is because the research shows us this is linked with the growing numbers of women that are obese in pregnancy. The hormonal changes during pregnancy because of the diet and the obesity affecting the growing fetus. And those effects are going to last long during childhood and also during adulthood. So you can see we are responsible not just for ourselves, but also for our generation, next generations, for children, our grandchildren. So my job as a basic biomedical researcher is to be like detective, to detect hormones that are changed during these stages that are involved in progression of the disease. If we want to have a better treatment and even a cure for any disease, it is our job to understand the fundamental for underlying mechanisms in the progression of the disease. And once we've got an idea, then the challenge is how are we going to translate this basic discovery into a clinical solution and a better clinical care, and that we can offer it to Janice to take it to clinic and offer it to her patient in addition to the prescription of do exercise more and eat less unhealthy. Perhaps we can imagine a pill that can deliver all the benefits of an exercise without living coach. So as far as we do support research, then we can have for the better future. And also I want to stop here and thank the University of Manitoba and McNally Robinson for giving us this opportunity to share our excitement about what we do and what we hope to do for a better and healthier society. And also I'd like to thank every single one of you for coming out, listen and participate, hopefully in the question session, and for supporting us. And also through your tax dollars that allow us to, for our funding agencies that provide us with the funding to do our research for a better and healthier future, and paying my salary, of course. Thank you very much.
That was fantastic. The future definitely looks bright. There are a number of things that I would like us to acknowledge first. One, we don't have representation tonight from our Indigenous communities, and they're overrepresented in terms of obesity and type 2 diabetes. And we are on Treaty 1 territory, so if there are people here that would like to acknowledge that, we would like to bring forward questions maybe towards the end. The other thing I'd like to acknowledge is that a lot of people here have questions for themselves, but you are all conduits right now. So think about questions that you would want to ask for your family or for your friends that aren't here right now. I think positioning yourself as a reporter in the room, and you know that your taxpayer dollars have gone to pay for the salaries and the research here, so you get to interrogate people, but more importantly to bring back that knowledge back to your home to share with people in your household or in your family that aren't here right now. So the next phase of this is, I've been told, the Phil Donahue Hour. For those of you that remember Phil Donahue, there's some younger faces in the room that don't know who that is. But I'm going to walk around with a microphone and ask some questions. So, do we have any questions from our panelists?
You can probably hear my voice, I think. There's a bit of a dilemma. among us older folks when we start hearing things. And an example is I was watching a documentary on the fact that older men have low levels of testosterone. And when you watch the documentary, it talks about it tends to happen in people that are obese or overweight. When you lose the weight, your testosterone levels seem to improve, but it's never is the low testosterone level because you became obese, or when you became obese, where's the causality here? If I wasn't obese, I wouldn't have low testosterone levels, or I have low testosterone levels, so I'll become obese.
So I think we have two experts here. Who wants to take the first crack? Dr. Ho.
Sure. So what we recognize is that when there is obesity, it causes an imbalance in hormones, where it leads to ultimately decreased levels of total testosterone, which is what the lab measures, which is what you'll see when you go to your physician and you'll get your testosterone checked. They'll say this is the test and your total testosterone is low. It's more complicated than that though. So when we investigate further and then we do more tests to look at not just total testosterone but the actual active testosterone levels, often that turns out to be normal. So it's that imbalance in hormones where the initial test may look to be low, but when we do additional tests, the active testosterone level ends up being normal. And it usually is obesity leading to this imbalance in hormones that leads to decrease in total testosterone. It's not the other way around. What we also know that in an aging male, they don't go through menopause, they don't stop having periods, and they have their rapid loss of testosterone. But what we know is that testosterone levels in an aging male does decrease as a male gets older. It's just not as clear in a male as it is in a female. And we know that with chronic medical conditions, including diabetes, heart disease, being overweight, that level does get lower, and it's associated with having chronic medical conditions. So it's not that low testosterone leads to this, it's that these chronic medical conditions lead to the testosterone level being a little bit lower.
Any other pressing questions right now?
I'm aware of somebody who's newly diagnosed with type 2 diabetes, and now there seems to be a thyroid issue going on. Is that again another hormonal situation, or can you help me there?
So you will hear about diabetes and thyroid diseases being associated together, but that's in the setting of type 1 diabetes and thyroid disease, because both of those are autoimmune conditions, which means the body is reacting against itself and making the pancreas not work well or the thyroid not work well. In terms of type 2 diabetes and thyroid problems or thyroid abnormalities, those would be two separate medical conditions.
Oh,
All right, I have a question for Jen. You were telling me that canola oil is my best source of omega-3 fatty acids in Manitoba. So if I ask for a donut deep fried in canola oil, is that going to protect me from the consequences of that donut? Because sometimes when I read things, they're like, these chips are high in fiber. And I'm like, ooh, should I eat these chips because it looks like it's high in fiber? So could you kind of clarify what those benefits are, and does it overcome some of the bad food that I'm eating?
Okay, so first a disclaimer, I like donuts a lot. Even as somebody who studies a lot of nutrition, I still succumb every once in a while. But I would say that it's partly about, there's this old saying in nutrition, everything in moderation, right? You've heard that. So it still holds somewhat true. I think that if you had to make a choice between fatty deep fried chips versus chips that are baked and have fiber, well, if you like the ones with fiber in them, then yeah, choose those ones. But I don't think that something deep fried in canola oil is going to be protective per se, because you're still getting all of the calories, you're getting the sugars, you're getting everything else in there that's not good for you at the same time.
All right, we have a question from the back, another budding scientist.
Well, if diabetes, if someone had it And if they don't sleep at night, what could happen?
So I think the question was, if someone had diabetes and they don't sleep at night, is that right? And they can't sleep at night, what could happen? Dr. Hope?
Well, we know that there are a number of hormone changes that occur in somebody that's sleeping overnight. Basically, when somebody sleeps, it's the time for their body's hormones to promote growth and promote kind of energy saving. I think if somebody doesn't sleep, or if somebody, say, works night shifts, that those hormone changes that happen typically when somebody sleeps can get a bit disturbed. And in somebody with diabetes, what they may see is that their blood sugars might change unexpectedly. Usually it might go even higher than what they would typically expect if they were sleeping instead. So they may notice some blood changes to their blood sugars because of that, the hormone changes that occur when someone sleeps.
Maybe I'll just follow up on that. What if someone was a little bit nervous to go to sleep if they were living with diabetes because maybe they're worried that their blood sugars might go low? Is it tough if you don't get enough sleep?
Yeah, so ultimately, good sleeping habits is going to lead to consistent patterns of blood sugars. Ultimately, when somebody has disrupted sleeping habits, it's going to lead to disruption of the normal sleep-wake cycle. It could lead to disruption of the normal cyclical rhythm of hormones that we see, going from daytime to nighttime. And ultimately, it may lead to disruption in the blood sugars. Typically, they may see sugars that aren't normal for them. We would say generally as a rule of thumb, the sugars would be higher than usual, but anything could happen. It could be lower than usual, it could be the same as normal. But when there's stress, when there's changes in sleeping, and that all leads to disruption of normal kind of physiologic hormones, then we can see some abnormalities, not abnormalities, but changes in blood sugars that they wouldn't typically see.
So actually, one of the words that came up that reminded me of sleep is leptin. So I read somewhere that if I don't sleep enough, so these scientists, they got people into a room, they paid them a couple $100, and they asked them to only sleep for 4 hours. And when they only slept for 4 hours, their leptin levels changed. I can't remember which direction. But when they got up, they had a voracious appetite. They couldn't really control their appetite. So can you maybe tell me what's going on and what's happening? What is this leptin hormone, and isn't it like a magic pill? Couldn't I just be taking leptin and help regulate my appetite?
Well, that's not a problem. Leptin is one of those hormones that is produced from fat. So as we become obese and we're gaining weight, we're going to have more leptin. So it's going to be a good thing. It's going to tell our body that we should be controlling our appetite. We just had enough. We should stop. But the problem is we go to a state, we call it leptin resistance. So the leptin is not going to be signaling appropriately that would do the job. So I think in that case, because they were healthy and they were not having the problem, if they, by the sleep disruption, they get their leptin lowers. So that's why. So they would probably, if you give them, provide them with some leptin, they could control their appetite. But with the obesity, it's not that easy. We need to figure out, they have excess amount of leptin in their circulation, but it's just body doesn't respond to it. So we have to figure it out, how are we going to use the leptin that they have. So it's like a key into a lock. If the lock is disrupted, we need to find out the lock. We have the key there, but it's a little bit more complicated than what it is with the healthy individuals.
It's related to that too, the leptin. Is that so if you don't, is it that you don't know what the key or what the lock is, or what leptin goes into?
So every hormone interacts with its partner. It's called a receptor for that specific protein. So in the leptin resistant, the receptors are not signaling appropriately, and there is a whole range of it. It could be the receptor itself, or it could be the molecules that are downstream of that signaling pathways. So there are so many layers in complexity that any one of them goes wrong, it's going to be disrupted. So, and it is very different in different individuals, and that's how it's so difficult to treat one part of leptin resistant in one individual versus another one. So that's the complexity of the system.
I just want to know what can be the main reason or the cause. Say, for example, in an individual who is turned diabetic after 50, he has a normal BMI, no cholesterol, no normal BP. He does regular exercise for like 30 minutes or so. When he goes for a glucose test, his fasting glucose is absolutely normal. Postprandial, it's above 200. So what, apart from insulin, what can be any other reason beside it? He being termed as diabetic.
So he lives in the US.
Sorry, so when you say aside from insulin, what else could it be? Or do you mean, okay. So diabetes is a spectrum, and that's why it will affect all different people of shapes, sizes, ages, all that kind of thing, because it is a multifactorial disease, which means it's not a single thing that will lead to diabetes, it's multiple things. Some things you can't help, including your genetics, your age, those things might, your ethnicity, those things, depending on some of those ethnicities and increasing age are risk factors for diabetes. But we know that diabetes is a spectrum where initially there's insulin resistance, and that happens with both lifestyle, so what they're doing in terms of exercise, what they're doing in terms of eating, but it's also genetics is a big role for that. And that's why you can see somebody who is lean and fit, and they may not be overweight, but they still develop diabetes. And what happens is their body just gets resistant to insulin, and that's why we see that pattern where the fasting blood sugar is normal, but when they eat or when they get a big glucose challenge or glucose blood test, the value after is high.
So what treatment can you offer him if he needs to be treated? So what do you prescribe for him?
Yes, ultimately you want to overcome that insulin resistance, because that's the problem there. It's not that they don't have insulin, it's that the fact that their body's not working or using up the insulin as well. They're more resistant to it. So lifestyle is always key. If they're overweight, getting them to try and reduce their weight, changing what they eat. Especially diet will play a big role here. So when there is a meal that has a lot of simple sugars, so things like pasta, white rice, white bread, so basically it's a very simple sugar, it gets absorbed right away, that often can lead to the body not handling that big sugar load with a bit of difficulty, and that leads to the increase in blood sugars. So changing what can be modified in terms of their lifestyle, their diet, and then using medications to help overcome that insulin resistance. And the first line medication, both in Canada and in the States, and essentially worldwide for type 2 diabetes, is metformin. And essentially it helps the body use their own body's insulin a bit better.
Great. I think we should ask a more general question to get going. Can you tell me what the word diabetes means? And I've heard there's type 1 and type 2. Are there other ways you can get diabetes when you're an adult that aren't either of those things, and what's that called?
Sure. So type 2 diabetes is the most common one worldwide. It is the one where it occurs in people that are a little bit older. There's a bit of insulin resistance. It's that multifactorial condition. And that's the one that can be treated with medications and potentially insulin down the road if that's what they require. Type 1 diabetes is an autoimmune condition. So the pancreas is the organ that's responsible for making a body's insulin. And in this case, the body reacts against the pancreas, and it ends up basically making that pancreas unable to make the insulin the body needs. So these individuals tend to present much younger because it's something they're born with. They may have other autoimmune conditions in their medical history or in their families. And there's a form called MODY, M-O-D-Y, which stands for Maturity Onset Diabetes of the Young, which is a which is a single gene abnormality that can also lead to diabetes. So lots of different kinds of diabetes, but type 2 diabetes is by far the most prevalent.
When I read the nutritional labels of products in the store, they always list sugars. But sugar is only listed in grams. It's not given as a percentage of our daily diet. So if the government ever establishes a percentage, or if you were to establish a percentage what would the percentage for an adult be of sugar? Did that make sense? In your daily diet.
So, Jennifer, you want to take that one? Do you want to disclose that maybe you're not a dietitian? and then you don't want to overstep your bounds? Or are you a dietitian?
I'm not a dietitian.
Okay, so you got to be careful. You don't want to go too far, right?
Okay, so
So how much? So normally, you know what would be really nice? You know what I think they should have on those stickers? Is a color code. It should be red, yellow, or green, right? So if there's no sugar, green, boom, I can buy it. I can buy as much as I want. Yellow, maybe not so much. Red, just stay away from it. So, right? Instead of, because right now when I look at it, everything's different, right? The content, so per serving or per 30 grams or per 100 grams. So I think the question was, what is our recommended daily intake of sugar in grams? If you don't know, that's okay.
I don't know where to find the answer, so I don't have it.
There you go, that's a good idea. So where would we go find that answer?
So there are, Health Canada puts out nutritional guidelines, so a Google search would take you there.
Okay. How about some important things when I'm reading those labels?
Okay, so one thing to consider when we were talking about this red, yellow, green hypothetical system, is that when you're reading labels on food products and you see fat-free or low-fat or sugar-free or low sugar, consider that if they're taking something out of the product, they're putting something else in to make it taste good. Because if they're taking out the sugar or the fat, those are the flavor things. That's what's going to make you want to eat that product. So often, what you won't see in a fat-free product is that they've amped up the carbs or the sugars in that product. And there's some evidence to show now that a diet high in carbohydrates is just as bad for you as we thought a diet high in fat was for you 20 years ago. So just something to consider with dietary balance.
I'm going to ask one question from Martin because he hasn't had a chance yet. And he's working in my lab. So Martin, you said something about metabolically healthy obesity. Can you tell me what that is? And I know you've published a paper on it. Can you tell me what are the best predictors of being metabolically healthy but overweight at the same time?
I wanted to talk about that, but I kind of went fast previously. So metabolic healthy obese means that people are obese based on BMI, for example, or it could be waist circumference, but let's say BMI. So your weight and it's I'm looking for okay, your
weight's a little higher than it should be. Like your BMI
for your height.
For your height, okay. Relative to your height.
Yeah, that's what I was looking for. Sorry. Okay, so but those people don't have usually they don't have typical risk factors. So the typical risk factors that we know. So for example, cholesterol, blood pressure, high blood glucose level. So they don't have it, but they have high BMI, so they're obese and healthy. What we saw in the literature, just before to come to our paper, is that those people have less visceral adiposity. So there's different compartment of fat. There's abdominal fat, but there's also some abdominal fat that is kind of deeper around the organs. And apparently those
what's abdominal fat?
So abdominal fat is the fat around the abdomen, so right here. So those people apparently don't have as much as abdominal fat deeply in there around the organ. So that's the kind of fat that is detrimental for your health. That's what eventually is going to cause metabolic disturbance, so high blood sugar, hypertension, etc. But in our lab with kids, we identified that it's not visceral fat mass that is the best predictor of being that kind of individual. It's actually the amount of lipid you store in your liver. So if you don't have like fat in your liver, you're more likely to be healthy and carry out the absence or the lack of risk. being like an immature. That was kind of.
All right, thank you.
I think you hear me. When it comes to frequent and excessive consumption of alcohol and obesity, cause of obesity and diabetes, what's there to be said about that?
Who feels comfortable with that one? Dr. Ho?
Sure. So, when there's frequent consumption of alcohol, first of all, it tends to also be associated with a lifestyle that's not what we would call an ideal lifestyle. So, the diet may not be great, the exercise may not be great. So, a lot of the lifestyle things that we know can put somebody at risk of diabetes can be seen in somebody that also drinks excessive alcohol. Alcohol has a lot of calories as well. So then you're just having a diet and a lifestyle potentially that may not be the healthiest and can lead to, can play a role in the development of diabetes. And we also, so I think that's about all I can comment on that.
I one time had a coroner actually tell me that a person that died of diabetes mellitus, and we knew that they consumed about a large bottle of strong liquor every day. And I said, what is that? They said, well, that is what would tend to cause that. And I think large, and I don't mean like 3 or 4 drinks, I'm talking about serious drinks. And they said, he seemed to indicate that it causes damage. Does that fall into the type 2 thing, or?
Can you damage your liver or your pancreas with excessive alcohol intake?
Absolutely, yeah. So when somebody's drinking excessive amounts of alcohol, and from the sounds of it, somebody is drinking a full bottle of hard liquor a day, that's well above what would be healthy. It will lead to other organ problems, particularly the liver of concern. When the liver is not working properly, the whole body doesn't work well. So pre-existing medical conditions like diabetes will be much more challenging to manage. And also, if somebody who is drinking excessive amounts of alcohol, then even just their regular care for their diabetes is likely not optimal. And in somebody who's not looking after their diabetes, then that's going to lead to increased complications, and it is associated with an increased rate of early death.
Never mind all the calories that come with all that alcohol.
I have a question about, I guess, the lipids. There's always, people are compared, or very often described as being pear-shaped or apple-shaped, and one supposedly is worse than the other. And then the exercise that can be applied to get rid of this pear or this apple.
Great question. So I'll go to Martin for that one.
That's also a tricky one because actually, if you look at the literature out there in terms of exercise is good for your health because it's target also the visceral fat that I was talking previously, which correspond more to the apple kind of shape. So this is where I'm saying it gets tricky because in terms of targeting specific, also what we call the spot reducing, there's no scientific evidence supporting that right now. Like in terms of saying, okay, we're going to exercise and try to reduce, let's say, like you said, around the thigh, around the hips, or let's say someone would like to lose some fat around the triceps. It's not something that we have, scientific evidence to prove that. However, for the visual adiposity, there's a lot of study out there suggesting that as soon as you start to exercise, the visual fat is one of the main fat that we can mobilize really quickly. And so we saw that a lot with different kind of RCT that were done by a researcher from Ontario, where they basically look at aerobic exercise, but without caloric restrictions, and people didn't really lose weight at all, but they definitely reduce their waist circumference a lot. And if you start to exercise, actually, most of the time it's something you're going to notice pretty quick. The weight won't change that much, but in terms of waist circumference, most of the time people, they feel a small, a loose in their pants sometimes.
It's confounding to me though, because when you exercise, any fat returns to muscle. May be heavy, may make you in fact heavier.
So
on the scale, I mean.
Right, so let me just repeat that for people that didn't hear that in the back. So the question was, if you start exercising, you turn fat to muscle. So your body weight doesn't change, right? Like you tend to stay the same, but what Martin is saying is that you'll get to move your belt an extra couple holes to the
Correct.
right.
Correct. In terms though of changing fat and muscle, I think we have to be careful here. It's kind of a slippery, slippery. Oh, thank you. Thank you guys. Slippery topics, especially with older adults. And I'm saying that because I also work a lot with older adults where we put them under resistance exercise, try to make them gain muscle mass. So it was pretty targeted in terms of what kind, typical type of exercise to gain muscle mass. That never happened with a gold standard measure of, lean mass. So we have to be careful when people say, oh, I exercise, but actually they went on a treadmill 5 times a week. Which is not, the kind of exercise you would do to increase muscle mass. Sometimes it's just they don't lose weight; they just, reduce the waist circumference.
What exercise do you suggest for older adults?
For older adults.
Or gray-haired adults?
If we have some Canadian physical activity guideline for that, which is about 150 minutes of moderate to vigorous physical activity for the aerobic component part. So we're talking about biking, walking on a treadmill or running. And also that includes 2 days at least of resistance exercise, which is also really important. So we're talking about weightlifting. That doesn't mean, like the weightlifting, keep in mind it's not to increase your muscle. We don't want to make you Arnold Schwarzenegger or someone like that. It's not the case. It's more in terms of increasing muscle strength, so which is really important. It's a strong predictor of mobility, also a strong predictor of mortality. And I'll always say that there's one test, which is a hand grip strength test, and it is correlated with a lot of stuff, also mortality, and I'll always say that it's going to predict almost the time and the days you're going to die. Like it's really well correlated with a lot of stuff. Just a joke. Okay. So increasing muscle strength is really good because it's going to help you in your daily task, like going to the grocery. You're going to come back with maybe 2, 3, bags in your hands. You won't ask to the neighbor to help you. So it's the kind of exercise that I would recommend for sure.
Yeah, I have a question for you as well. You were talking about exercise intensity and how the same intensity produces different effects for different people. Could you please comment on the heart rate as a means of measuring exercise intensity? And how do you do that in your research? How do you measure exercise intensity for different people?
So, in our research, we have some Art of the States equipment. So, we are doing some VO2 Max tests at first, and we base our prescription on a percentage of their VO2 Max. Or most of the time, what we're doing is actually on the VO2 reserve or heart rate reserve because they are well correlated.
Sorry, what's a VO2 Max?
Okay. So, sorry about that.
Maybe I'll do this. So what a VO2 max would be, if I put everyone on a treadmill right now, and I kept increasing the speed by 1 mile an hour every minute, until you shot out the back. The last second before you shot out the back, that would be your VO2 max. And whatever your heart rate is at the end of that test would be your heart rate max.
Correct.
Or if you had to run to catch a bus or run away from a bear, that would be your heart rate max. And then?
So we use actually the heart rate we obtain on that test to prescribe the exercise we're going to prescribe to those participants. So for example, in some trials that we have done, we perform a VO2 max, and then we use what we call the VO2 reserve, which is the score you get on that treadmill before you fall, minus a constant, and that's your VO2 reserve. So we use after that like a formula, a percentage of that VO2 reserve, which take into consideration the heart rate max you got on the test, but also your heart rate, resting heart rate. And then with the measure we have, the range in terms of heart rate. So let's say you want to work at, you're supposed to work out within 50 and 60% of your heart rate reserve. Then we're going to find out with the formula and the test we've done, the heart rate that corresponds to that percentage. And then we're going to ask you to stay within those ranges. So we're going to ask you to wear a heart rate monitor, and then when your heart rate is going to be within that range, then that's where you're going to keep, the intensity. You're going to keep the intensity at that level.
So I would say, talk to an exercise professional to get those numbers, right?
Yeah.
Right? So, and the other thing is, if you're reading that on the treadmill, right? Sometimes the treadmill will have your green, yellow, red zones. A lot of times it's different for different people, so you don't always have to trust those, especially if you're on some kind of medications that might otherwise affect your heart rate. So if you're on some of those medications, get tested by a professional, Refit Center. If anyone's from the Refit Center, hands up. We're going to come find you. And then get that tested. Otherwise, for people just going for a walk, you would want to say, yeah, feel like you're 7 out of 10 or 6 out of 10.
So if you're walking and you cannot maintain a conversation, or you struggle to maintain a conversation, basically you are within the good range to get some health benefits, or to have the kind of exercise that,
Don't talk to your friend.
Yeah,
right.
Well,
find a friend you don't want to talk to, and then ask them to go for a walk.
A couple of quick questions. On the news, there's apparently a pharmaceutical company developing an exercise pill. Basically to increase your metabolic rate. And my second question is surgical intervention. If you have a grossly obese person and they undergo some sort of surgical intervention like liposuction or stomach banding, does that improve their health?
So for the pill part, it was more a comment than a question, but what I would say about that is I'm actually in favor of a pill of exercise, and I would, let me explain myself here, for people who actually cannot exercise. So we know that some people cannot exercise for different reasons. They have health issue. I think in this case it's something interesting. I think though we are, like you said, maybe they are in the process of creating a new pills, but so far I think we're kind of not there yet. I didn't read the article. I wish I would. But I'm, in favor of a pill in that specific case. In that specific case.
So before we get to bariatric surgery, actually Hannah said something about trying to find the magic pill. So can you maybe comment, and then we'll go back to Martin and then Janice about bariatric surgery?
Yeah, again, the exercise pill, yes, there are different research groups that are trying to generate one, but they've been tested only in animals models, and they haven't been going to any clinical trial, and nothing so far come out. But in order to get to that stage, we need to understand a lot more about the physiology of exercise. As Martin mentioned, we need to find out how exercise works, what are the benefits, how it's going to exert its benefit. We need to understand the molecular basis for that in order to be able to generate something that can mimic the exercise, and we're still not there. We know that the intervention, we use it as an intervention and it's best. It's the greatest so far, but we still don't know how it works, and we still need to do a lot more to get there.
And in terms of surgery, you mentioned an interesting point here, which was the liposuctions. So there's a group in the States who basically took off about 10 kilogram of abdominal fat from liposuction. So it's a huge amount, right? And they look at different marker of inflammatory marker, cholesterol, blood glucose, all those typical risk factors. Even though they didn't see any improvement at all, and it was a lot of weight. And the reason why is because it's subcutaneous adipose tissue. So there's those handle you have here. So it's basically what they took off, right? They didn't went really deep around the organs, which is the more detrimental fat. And so for the bariatric surgery, I guess.
So they also did bariatric surgery in another group of patients, and they lost the same amount of weight around here, but deep inside, and they saw all the metabolic benefits. So the vacuum didn't work, but losing the weight around the belly did, and as Martin said before, no magic pill yet, but exercise is the way. Shoelaces, no, not pills. Any comments on either bariatric surgery, pills for exercise, or new drugs that are on the market to help us lose weight?
Two main types. One is a restrictive kind of bariatric surgery. So the anatomy is the same, but a device is put in place to try and restrict how much can actually go into the belly, to put it simply. And then there's ones where there's actual bypass. So there's actual rearrangements of the gastrointestinal tract, of the food tract. What we've seen is that in both of those kinds of surgeries, people that have diabetes and are overweight do have significant improvement, to the point that some people actually, their diabetes goes into remission. It's not clearly understood. We know that the gut hormones get disrupted in people that have long-term diabetes, and with bariatric surgery, sometimes there is restoration of these gut hormones, and blood sugars can improve quite significantly, again, to the point where the diabetes is thought to be in remission.
That means you no longer have diabetes.
You do no longer have diabetes. I think we hesitate to use the word cure because it doesn't cure diabetes, but essentially it puts the blood sugars into a normal range, but you can still develop diabetes again. People that tend to do better with this kind of surgery are people that have had diabetes for a shorter period of time. So if you've had diabetes for 20 years compared to 1 year, and people that also do better tend to lose more weight. So somebody that loses 100 pounds after bariatric surgery versus somebody who only loses 20 pounds. So the person that lost more weight and had diabetes for a shorter period of time tend to do better. There's an existing study going on right now that's looking at kind of the long-term outcomes of weight loss surgery and diabetes. And right now it's just reported on their 3-year outcome, but they're going to continue to follow these patients. So right now we know at 3 years, their numbers still look quite good and people still are in remission for their diabetes, but we don't know, is it going to last for 10 years or 20 years or whatnot. So we're that study is still ongoing. And just a few things to think about. Bariatric surgery on average costs about $5,000, $6,000. The average lifetime cost of type 2 diabetes in the United States is about $80,000. So although bariatric surgery may seem more expensive up front, when we look at the cost-benefit analysis, it's definitely thought-provoking. The other thing is the wait time for bariatric surgery in Canada. Across Canada, it's about 5 years. Here, it's actually pretty good. It's only about 2 to 3 years, but it's not something that you can just go and get done in the next 6 months. It's definitely something that's a bit of a process. And ultimately, it has to be somebody that can stay with their new diet once they've had bariatric surgery. So if they, you can actually out-eat your bariatric surgery and put on all that weight back, and then a lot of those benefits that we can see with bariatric surgery go away.
Hello? Okay. I have a question about physical activity. So in order to reduce our risk factors for developing diabetes or obesity, are we better off exercising once a week very vigorously for 2 hours, or should we be
exercising every day for 10 to 20 minutes? What's better?
Actually, I really like the fact that when you exercise, if we're talking about diabetes, let's say someone has diabetes and they start to walk and they poke themselves, they measure their blood sugar before starting exercising, and while they exercise, the blood sugar is going to go down. And so it's like there's an acute effect of exercise on blood sugar. So if you start to exercise, let's say 3 times a week, and then you go to 5 and 6, then you're going to have like a sort of accumulation of those, small acute effect, which is going to help you to manage your blood sugar. So I would say like the recommendation are always about a certain amount of minutes per week, but the more you do, the better it is. So, in terms of recommendation, I would always say, well, start with something that you think you can achieve, you can do. If it's only once a week, start with once a week, then increase 2, 3. And if you can go up to 5, then that's perfect. That's awesome. That's what I would do.
And if your doctor gave you a pill to take every day, and you took all 7 on Saturday, it might not work as well as if you took it every day. So, good point.
John, there was a question.
One more question back here, and then we'll go back.
Okay, this one is for Jennifer. Jennifer, the primary sources of omega-3 are from plant source mostly, so they are shorter chain of fatty acid versus the ones that our body utilizes as fatty acid. Omega-3 are of a higher chain. And very little of it actually converted to those higher chain ones. So, is there any other direct benefit of these omega-3s as far as obesity and diabetes is concerned, or it's just...
Okay. Yeah, so we're talking about the difference between the long-chain omega-3 fatty acids that are in fish oil, EPA and DHA, and the ALA, which is a precursor to those on a slightly shorter fatty acid chain that's in canola oil and flaxseed oil. So there is some controversy about whether ALA is converted efficiently to EPA and DHA in the body. Some of our results have shown that flaxseed oil reduces inflammation in obese animal models. So that's where we've seen benefits using flaxseed oil. Sorry. I think I've forgotten what the rest of your question was.
Was there a direct relation? Is there a direct contribution that they have as a short-chain fatty acid for us, or is it
That's still okay. Whether there's a direct action of the shorter chain fatty acids that could also have benefits, that's under investigation, and that's something that we're studying in my lab.
Where does olive oil go with those oils?
So olive oil is made up primarily of a fatty acid called oleic acid. It's a monounsaturated fatty acid, not an omega-3. But canola oil is 60% oleic acid, so there is a bit of a similar profile, although oleic acid doesn't have omega-3s. So there's some research being done on fatty acid composition, or sort of the balance of different fats and different oils. And both oleic acid, or olive oil, and canola oil have that high monounsaturated content, which is generally seen as beneficial. It's still sort of a fluid area of research, but as somebody who studies this stuff, I will say that I cook with both canola oil and olive oil. So those are my choices.
So if I'm going to Safeway after this, and I'm going to get oil for my stir fry, what do you recommend I buy?
I think it's called Co-op now.
Oh, Co-op, sorry.
This is related to exercise. I was just reading recently that during exercise it's very good to change the speed of your exercise. If you're working on the treadmill, you're just walking. And then you might do that for 4 minutes. And then you alter that by going very fast for another 2. And then back to 4, and then 2, and then 4. You just go 5 times. Apparently that's supposed to be beneficial for plaque in the arteries, or somebody's getting it out of your arteries. That kind of exercise.
What I could say about that, I'm not so sure about the plaque in the artery. I know it is used though in cardiology. for readaptations. So I guess it might have, maybe you know about that. But what I know though is that kind of a training, which we call interval training, is really good to increase your fitness level. So remember that treadmill test or that bike test, which gives you a score. Basically, that's one of the best predictor of your overall fitness. And so that's the kind of training people want to do to improve that fitness level or the score you're going to get on one of those tests. So it is really good for that. Yeah, in terms of artery and plaque, this one, well, I'm not so sure about that. I'm not that much sure, so I don't think I would give you, I could give you a proper answer.
Yeah, we don't know whether or not exercise can't really reverse that plaque as far as I know, but that type of training does improve your fitness. And Martin talked about your hand grip. So if you're able to open a beer bottle without a bottle cap opener, you're going to live longer. Probably the best predictor is actually your fitness. So the beauty of that type of training is that it boosts up your fitness really high. And the higher your fitness, that's probably the strongest predictor that we've seen for a lot of chronic diseases like heart attacks and strokes and even death.
And just to go on that fitness, there's some interesting study looking at people who have high BMI but have really high fitness level. And when they look at and really hard endpoint like mortality, those people are actually not at bigger or greater risk of mortality than someone who is young and fit. So this is something really important to consider if you have a type of, if you have to pick up some sort of exercise, you should definitely, choose the kind of exercise that's going to increase fitness level.
And it would also appear that you wouldn't have to do it for as long a time. Like you might get the benefit of doing a 4-2, say for 15 minutes a day as opposed to doing another kind of exercise for 30 years old.
Depending.
Is that the strength of interval training?
Well, I mean, it depends what is the purpose of your training. If you're looking at, weight management or weight loss, then if you're increasing your energy expenditure during exercise because you're going higher, then you're going to burn more calorie. But you're also going lower for a certain amount of time. But as you become more fit, you're potentially just going to increase those intervals, longer. So you're going to burn more calories. That could be a good strategy. So you can reduce the time as well at some point.
To give you the incentive to keep going, if you have to spend a longer amount of time, you get more
Yeah.
If you don't like it.
Well, yeah.
All right, so we're getting down to our last two questions.
Once you develop that deep fat that's so detrimental, is it possible with enough exercise that you'll be able to get rid of it as well, or is that once it's developed, it's there?
Well, actually, exercise is really good at reversing that kind of fat. I would not say that it's going to take it off, like, the whole fat, but it's going to reduce it for sure. It's one of the kind of fat that we have in our body that is mobilized pretty quick with exercise.
Okay, now I'm going to go a little further. What about diet? So pear versus apple. Is there a dietary approach to get rid of that apple? Is it an apple? Oh, that joke did not go well.
So, do we have an ideal dietary approach to get rid of that belly fat that
Martin said is so bad for us?
Okay, so again, I'm going to state that I'm not a dietitian, and I generally don't make dietary recommendations, even in the context of weight loss. But I don't know. Dietary recommendations really are intuitive in that eating healthy is what you guys have grown up knowing. Eating whole grains, eating more fruits and vegetables, and less sugar and fat and dessert and that kind of thing. In terms of actual weight loss, I guess I shy away from anything that's like a fad diet. If you hear about something new and trendy, I'd take a good look into it before I went ahead and trusted my health to a new dietary regimen, or I would talk to my dietitian friends or something like that. But yeah.
Magic bullets?
Well, I'm kind of specialist that I'm doing using different diets and different exercise in animal models to be able to understand how the hormones are getting changed there and how things goes wrong and how can I fix them. So I don't know as
So
much.
this is about animals. You're talking about animals right
yes,
now. Just so
I'm
everyone
very
realizes.
afraid to translate right away into
But what have we found in animals?
So again, we should not be eating too much of fat, we should avoid too much of sugar, and we should be doing exercise, because I just did a study where I fed my animals only for 3 days. I gave them high-fat diet food, and I can see, and they were young mice that they're supposed to, and I'm studying one hormone, it's called growth hormone, which is very important during puberty. So I give them this high-fat diet only for 3 days, and it was like 70% reduction in these levels of these hormones. That is critical to be very high levels at that stage of life. And then when I give them that diet and I ask them to exercise, and I swim them, and I could not see that reduction. So I can see that detrimental effect of the high-fat diet can be completely reduced and prevented by exercise. So we're trying to get these discoveries and translate them. How are they going to affect human population? But I cannot make any recommendation right now. But we know that eating healthy and less and doing exercise is the best so far. But we just need to get people to follow the protocols.
Especially during pregnancy.
Yes, can I just make an observation?
Yep.
I was here last month for the chronic kidney session, and they had only cookies, whereas this session is about healthy eating and not overeating, and they've got fruits and veggies. That's pretty great, hey?
Yeah. Except there are more cookies missing than fruits and veggies. Last comment about ways to reduce belly fat.
So in terms of reducing abdominal fat, it really is cardiovascular exercise. We've heard a lot about the different kinds of exercise regimen, how fast your heart should beat, how often you're doing it, should you do it in one big interval, should you split it up. Ultimately, any exercise is good exercise, and the best way to reduce belly fat is cardiovascular exercise.
Great. So I ran out of batteries, so that means the session's over. There's half a tray of cookies and a lot of fruit and vegetables here to come up. I'd like to thank the University of Manitoba for putting this on, for Janine for putting this on every month. I think back there we also have Dr. Catini, who helped organize this session and strategize who was going to be on board. This is our last session for 2014, is that correct? The next one will be January 14th, it's a Wednesday, and it'll be about sitting. So we're going to have 4 panelists on treadmills and bikes. Because they're not letting us sit down, I'll be one of the panelists. And we're actually going to do a debate, which I don't know if you realize that or not, about whether sitting is the next form of smoking. So if you wanted to come back, you won't be allowed to sit for an hour and a half. And did you have one more question? No? You're good? Okay. So, thank you very much for coming out. Our panelists will be around for the next 20 minutes, so if you're a little shy and you want to ask them in person, come on up.